Not all the patients with status epilepticus come to the ICU. Only about 30% of these patients. Most of them recover before at the hospital arrival, and they do not need ICU management.
Fellow Homo sapiens! In this week's Epilepsy Sparks Insights podcast, we hear from Stéphane Legriel, a critical care/ICU physician from near Paris in France, with a passion for helping people experiencing status epilepticus, which is an ongoing, very dangerous epileptic seizure. Stephane tells us all about different types of status epilepticus and his emergency care for people who experience it.
Hello Torie, hello everybody. I'm very happy to be here with you. So I am a critical physician. I work in an ICU, in an intensive care unit for 20 years. And I have a particular interest in neurocritical care on patients with epilepsy and status epilepticus. So that's my main point of interest in my job. I have a lot of points in interest, but this is the main one.
And whereabouts are you based? I mean, probably can tell by your accent, but if you could just tell everybody your location and your hospital.
I work in Versailles Hospital. It's near Paris in France. It's a public hospital. We have a big area of management of patients, and we have an emergency unit, a mobile unit with doctors going through the field to take care of the patient who are critically ill, and they bring them back to the hospital.
Why did you choose to focus on status epilepticus?
Oh, it's a big question. It comes from a long time ago. It was my subject of medical thesis, and it was something appeared to me important and to the director of my thesis at that time. We worked about EEG in the management of this patient, and it appeared very important to take care of this electroencephalographic aspect during the care we give to the patient with status epilepticus. And time by time, step by step, it became more important for me, and my understanding of the disease was better, and my interest increased similarly. And now it's one of my favorite point of interest in critical care.
And just quickly to remind anybody or to inform people who aren't familiar with status epilepticus, what is it?
Yes, it's very important because the definition evolved along the time. A long time ago, status epilepticus was considered when a seizure couldn't stop spontaneously. This is a general definition, but it's very important. And time by time, the definition has been precise. The last definition we use consider 2 time points. There is a T1. This is the first time when we have to recognize status epilepticus and to introduce a treatment. And the T2 time, it's when complication may occur, when status still is ongoing. So the definition of T1 and T2 depends on the type of status epilepticus. There is a classification in parallel, and this classification is an electro-clinical classification. So we consider status epilepticus depending on if there is a predominant motor signs or not predominant motor signs.
Of the seizures.
And according to it's complicated, but according to if status is with motor sign or not, and if it's generalized or focal, we recognize status epilepticus at different times. So, by example, in generalized convulsive status epilepticus, it's 5 minutes to define status epilepticus. When it's focal but without consciousness impairment, it's 15 minutes. And when it's focal with consciousness impairment, it's 10 minutes. And another example, in absent status epilepticus, it's 10 to 15 minutes to be identified and to introduce a treatment in emergency.
Okay, that's really interesting because largely we are told that, it's 5 minutes and that's it. And I suppose that's because the type of seizure that most people in the world are familiar with is the type of, sort of generalized seizure. So that's really interesting. So it can vary between 5 minutes, 10 minutes, and 15 minutes.
Yeah, it's very important, Torie, because the importance of the treatment we will introduce depends of that time. And some patients may have longer seizures to be tolerated before introducing this treatment, and it's important to respect that different points.
Tell us about the treatment that you provide for people who are experiencing status epilepticus.
It's very important. I make a parallel with cardiac arrest. It's a chain of management. There is a lot of actors that can act for the management of the people that experience status epilepticus. First, in the field, caregivers, proxies of the patient can act. First, we have to make airways free for the patient. We have to protect him from other injuries, just like traumatic brain injuries or shoulder dislocation, things like this. And we have to record time from the beginning of the seizure to 5 minutes, to 10 minutes, to 15 minutes. And according to that time, you have to call emergency services when status epilepticus is identified.
Which just shows the importance. If somebody's observing somebody else having a seizure, you must time it from the very first moment.
Yes.
And that includes timing it from the moment that a person might have an aura as well. That type of focal seizure is very important, just to note.
Yes, it's very important to note all the events that are associated with the crisis, with the seizure. If you have, by example, midazolam spray on the protocol determined with your doctor when you have epilepsy, and it's protocolized to give you this treatment when you are at the time corresponding to status epilepticus, it's possible to make it at home if it's already organized. If not, you have to call for the emergency services. They come to your home, they come to your office, and they give you the good treatment. And the good treatment, the first treatment of status epilepticus is benzodiazepine.
Generally Europe-wide, is it? Or generally, is that global, that is benzodiazepine is generally the first treatment? Everywhere
in the world, it's benzodiazepine.
What is your work when it comes to status?
I work in an ICU, so not all the patients with status epilepticus come to the ICU. Only about 30% of these patients. Mm-hmm. Most of them recover before at the hospital arrival, and they do not need ICU management. Most of the time, ICU management is required when status become refractory to first and to second lines of anticonvulsants. So not all the time, but most of the time, the patients require also mechanical ventilation because they receive anesthetics to manage status epilepticus. And this is the work of intensivists or critical care physicians to manage patients requiring this type of management. So when the patient arrives in the ICU, we use EEG, electroencephalography, to identify if there is an ongoing seizure. That can be only electrical. It's very important.
Oh, yeah, because sometimes it may be a non-epileptic seizure.
Yes, it can remain clinical. It can be subtle with only little twitch that can reveal the ongoing status. But sometimes it's only electrical, so only the EEG can identify the persistence of status epilepticus. Mm-hmm. And we give other treatment to control status. It's very important.
And what is the type of treatment you will give them?
We give anesthetics most of the time.
And why does giving an anesthetic help?
It helps because it's more powerful than other treatment. It's like you increase the level of management. You previously used first and second lines, mm-hmm. So the third line is anesthetics because it decreases the cerebral activity. Mm-hmm. And it modifies the seizure threshold, so we can adapt our treatment using EEG with electroencephalic goals to to break the status epilepticus.
So basically, making a person unconscious reduces their seizure activity.
Not really, because they can be conscious because of status epilepticus, but this is the aim of the treatment. You decreases the cerebral activity, so you do not allow seizure to remain, to persist.
So just to clarify, if you put somebody under general anesthetic, because that reduces anybody's brain activity, that reduces the seizure or stops the seizure?
We do both. It stops the seizure. The goal is seizure suppression, but
Yes.
but sometimes we also do something called burst suppression. It's a brain state of functioning that do not allow seizure to persist.
Oh, okay.
Yes.
That's cool.
We perform a sort of titration of anesthetics to obtain this goal.
This tells us why it's so important for observers of a person having a seizure to time it, because then you know when to potentially put them under general anesthesia.
Exactly. It's very important because when we have timed the seizure duration, we can know where we are about the first, second, third line of treatment and when to act to do something so important that is mechanical ventilation and anesthetic use.
And when you put somebody under general anesthesia, and so they're in this position, the patient, how long might they be under general anesthesia?
Most of the time we do it for 12 to 24 hours.
Okay.
But unfortunately, sometimes status reoccur after withdrawal of anesthetics. And it's called super refractory status epilepticus. And we have to do it again 24 hours. And if it's reoccur, we can do it for 48 hours. And if it's reoccur, it's very, very bad condition. We have some time to do it for 5 to 7 days. So It can be very long. It's rare. It's about 6% of the patients. But it's possible, and this is our job to manage these patients.
This has been so interesting, almost enthralling for my geek brain here, just to think about because I never, and I think most of listeners don't really hear about what happens in this situation. So thank you so much just for giving us a little bit of insight, Stephane.
Thank you, Torie.
Thanks so much to Stephane for educating us about status epilepticus, which is, pretty much a scary topic for many clinicians, patients and carers. But it is ultra interesting too. Make sure that you tune in next week to hear about Stephane's ICTAL group, an organisation formed to improve patient outcomes when it comes to status epilepticus.